They're based on radiology. My name's Dr. Ian Craven. I'm an academic fellow in clinical radiology from Sheffield. The first of the lectures, we're going to concentrate on the basics of a plain chest radiograph. Firstly, consider the following chest radiograph. Out of these 5 options, what is the most likely diagnosis? The answer to this question is B, acute left ventricular failure. We'll come back to this question shortly. The aim of this lecture is to enable you to confidently diagnose airspace shadowing on the chest radiograph. To do this, first we're going to look at a normal chest radiograph, in particular the anatomy. We're going to look at causes of airspace shadowing and look at ways to differentiate between them. So here's a normal chest radiograph. In the clinical setting, obviously the most important thing to do, first of all, is to make sure it corresponds to the correct patient. But in an exam situation, it's probably most important to look at the side marker, here on the left, and the orientation, here being PA as opposed to AP. When we look at the anatomy, I'm going to divide this into the lungs, the heart, and the mediastinum. And although this may seem a little basic, this is one of the fundamental starting points for a chest X-ray before we can look at the various pathologies that may be on it. Starting off with the lungs, it's very difficult to look at the lobar and segmental anatomy on a chest X-ray. As radiologists, we tend to refer to upper, middle, and lower zone pathology. However, we can use something called the silhouette sign to locate exactly where the pathology lies. The silhouette sign basically means you lose the normal anatomy on a chest X-ray. So here we see the right heart border, and if we lose this, we know the pathology lies within the right middle lobe. For example, here with right middle lobe collapse, and here with right middle lobe consolidation. On both of these radiographs, we can see we've lost the right heart border. If we lose the right hemidiaphragm, we know the pathology lies in the right lower lobe. So here, we've lost the right hemidiaphragm, the consolidation lies within the right lower lobe. On the left, if we lose the left hemidiaphragm, the pathology is in the left lower lobe, and here we can see an example of that. On this chest X-ray, we've also lost the right heart border, so there's right middle lobe pathology as well, and this is a good example of dual pathology. If we lose the left heart border, we know the pathology is in the lingula. This is less commonly seen. When we look at the anatomy of the heart, it's important to look at the mediastinal contours running down the left and right side of the vertebral column. If we start at the top, we see the aortic knuckle, followed by the left atrial appendage and the left ventricle. On the right, we see the right atrium, but we don't see the right ventricle. It's not outlined on a normal plain chest X-ray. It's important to understand that there are normal variants. Here we see a right-sided aortic knuckle, often misdiagnosed as paratracheal lymphadenopathy, but this is a normal variant. It can be associated with other pathologies, but these are not seen on this plain film. Here we understand the importance of looking at the site marker. There's a right-sided marker on the film and the heart shadows on that side. So this is situs inversus or dextrocardia. When we look at the heart in a PA projection, we can measure its size, and the line A here is measuring the diameter of the heart. By measuring the width of the thorax, line B, just above the level of the diaphragm, we can work out the cardiothoracic ratio, which is simply found by dividing A by B. A cardiac thoracic ratio of greater than 0.5 means there's cardiomegaly, and there's common causes for this, including cardiac failure, hypertrophy, and pericardial effusions. There are many other causes, but these are the most common. When we look at mediastinal anatomy, I think this is the most poorly understood. If we look at this chest radiograph, we can see the right pulmonary artery and the left pulmonary artery, which is slightly higher. We can also see the upper lobe vessels. This is, as I say, poorly understood, and I'll go back to the plain film just so that you can convince yourself that you can see those vessels. We'll come on to, in future lectures, why it's important to be able to identify these vessels and when they're abnormal. So we'll go back to question 1 and consider the chest radiograph. If you remember, this was the radiograph that was shown, and we said that the most likely diagnosis was left ventricular failure. Let's look at why that's the case. The airspace consolidation that we can see is in a perihilar distribution. It's around the pulmonary vessels. There's loss of the right hemidiaphragm, so we know there's pathology in the right lower lobe, and this is likely to be a small pleural effusion. And we can see that there's an increased cardiothoracic ratio, so there's cardiomegaly. So putting all of these together, the most likely diagnosis is left ventricular failure. Of course, there are other causes of airspace shadowing on that list, and this chest radiograph could represent any of those, but the question specifically asked for the most likely diagnosis. When we talk about airspace shadowing, we're talking about pathology in the alveoli. Here on a normal chest radiograph, you can see the alveoli are air-filled and appear black. When there's pathology within the alveoli, they appear white and there's a fluffy appearance. There's no lines apparent. Airspace shadowing or consolidation can be due to a number of reasons, and these are very difficult to differentiate on a chest X-ray. It could be due to pus or infection, pneumonia, fluid with heart failure, blood in the case of trauma, or cells with bronchoalveolar cell carcinoma. This is another example of airspace shadowing. We can see here that there's loss of both hemidiaphragms, suggesting bilateral pleural effusions. There's upper lobe venous diversion, and there's sparing of the apices, so this is another case of left ventricular failure. Here we can see a chest X-ray where the airspace consolidation is in a perihilar distribution, so again, this is most likely to be fluid overload or left ventricular failure. Here's another example of left ventricular failure with loss of both hemidiaphragm and airspace consolidation in the lower zones. Question 2, consider the following chest radiograph. In this case, what's the most likely diagnosis? So the answer to this is E, a pneumonia secondary to Streptococcus pneumoniae. And if we look at the chest radiograph, we can consider why this is the case. There's loss of the right hemidiaphragm, so as we've said before, this indicates right lower lobe pathology. But we've still got the left hemidiaphragm. We've got the left heart border and the right heart border. And in this case, the projection's AP, so we can't comment on the heart size. But there aren't any other signs of left ventricular failure or heart failure. Here's another example of a lobar pathology. This is a patient in intensive care. Several days later, we did another chest radiograph, and there's loss of the left hemidiaphragm, indicating left lower lobe pathology. It still looks the same on a chest radiograph. Airspace consolidation looks the same no matter what the cause, but it's the other coexisting findings that lead us to suggest that it's infection rather than fluid. They're on intensive care, and there's only pathology within the left lower lobe. There's many different pathogens that can cause lobar pneumonias, but Streptococcus pneumoniae is the most common. So in summary, we've looked at a normal chest radiograph, we've concentrated on the anatomy and the basics of a chest radiograph. We've looked at the silhouette sign and used it to localise where the pathology lies, and we've looked at how to diagnose cardiomegaly, particularly on a PA chest radiograph. We measured the cardiothoracic ratio, and then we looked into airspace shadowing and the different causes, and it's important to remember that we can't differentiate between these on a chest radiograph. It's the other clinical findings that help us diagnose what's happening within that patient. That's all for this lecture.